Welcome back to case 42.
Welcome back. So in case 41, we were talking about a case of a young male patient with less than 2 years of symptom duration, which was referred to rheumatology with suspicion of axial spondyloarthritis. And this case happened in the same week as a previous one. This is a 32-year-old male patient who was referred for the first time to a rheumatologist with 8 years of symptom duration, and the patient never received a clear diagnosis explaining what is going on actually with his back. You see that overall there are typical inflammatory characteristics of this back pain with insider's onset, with pain at night, with awakening early in the morning, with long standing morning stiffness for 2 hours and longer. There was no clear improvement recently with rest, but also with exercises, and there was no radiation of pain. Patient, because there was no clear diagnosis, tried only a little bit of NSAIDs with diclofenac 25 milligram. That is suboptimal in the case of inflammatory conditions, same as true also for low dose ibuprofen, but there was some improvement of back pain even with these low dose NSAIDs. So also in this case, no other typical spondyloarthritis manifestations that probably also resulted to some issues with previous diagnosis. No family history of spondyloarthritis. He works in the office and does jogging, but no excessive physical activity. At the examination, again, good general condition, no overweight. At the physical examination, there was some tenderness over sacroiliac joints noted and no peripheral manifestations, slightly decreased lumbar spinal mobility with shoulder of 3 centimeters, and otherwise spinal axial mobility was normal. In the lab, HLA-B27 is positive and CRP is clearly elevated, also in this case without any other reasons for elevation of the CRP. And also in this case, because everything is limited just to back pain, we need to differentiate axial spondyloarthritis from other potential causes of back pain, and that is why imaging will be very helpful also in this case. So it is still recommended that X-ray is a method to perform first in the case of suspicion of axial spondyloarthritis. In case of very short symptom duration, it might be questionable whether X-ray would be of great help. You saw in the previous case there was not that much structural damage on MRI. In this case, X-ray, if available, might show something. And in this case, X-ray was performed. What do you think? Do we see something compatible with the ASAS?
Let's have a look at the X-rays. X-ray of the pelvis, I said it before, is an easy method, is a cheap method. It has a radiation of maybe 0.8 to 1 millisieverts. So this is not a low radiation, but it's okay. And you can do it in 2 or 3 different ways. There are 2 options that are established: the anterior posterior view. That means the X-ray beam is 1.2 meters in front of the detector. The patient is in between, and you have an horizontal beam. And then we also have the Ferguson view, where we have a 30-degree angulation, and then we have a more oblique approach. So it takes a little bit more of radiation dose because there's more soft tissue to transmit. And the projection is different, but it's very preferential for the imaging of the sacroiliac joints. And here in our patient, this is in fact a male patient. So in males, we don't have the full circle of the true pelvic ring. So it's rather like this heart-shaped configuration. And I would say this is an anterior-posterior projection. So we see the hips, the trochanters, they all look in a normal shape. In Ferguson, they would be enlarged, and you would not be able to judge this. So here we, of course, focus on the sacroiliac joints, and these joints are imaged by X-rays, and you search for erosion, you search for sclerosis, and you also search for ankylosis, because the chronic sacroiliitis leads to all these three findings, and it can be already very pronounced already in an intermediate stage of the disease. And we do not have the comparison with a normal anatomy here in this case or in the previous case, but I'm sure in the other 40 cases collected in the ASAS online case library, there are a lot of X-rays with normal apparent joints. Here we see a lot of sclerosis on the right side and also on the left side. We see large erosions. That is this defect over here, smaller defect over here, huge defect here, also corresponding on the other side. So this is really like a textbook-like example of erosions in the sacroiliac joints. What you can see in addition is a difference between the iliac bone and the sacral bone. You see the sacral bone is still well preserved here, but here we have this ill-defined contour. So we would assume that more erosions are present on the iliac side of the joint compared to the sacral side. Here on the left joint, this impression is different because both joint parts are more or less irregular, and I would already say that we see here no joint space at all. So I would assume that there's some ankylosis already here in this part, leading to fusion of the joint. In terms of grading, we would have a grade 3 on both sides. Grade 3 is defined by an ill-defined joint contour with large erosions, a lot of sclerosis. We have that on both sides. And we also have partial ankylosis. And here we can debate if we would that grade already as a grade 4. But looking into the original publications, full ankylosis or almost full ankylosis is judged as a grade 4, and partial ankylosis is still contributing to grade 3. Which is debatable, but still I would say this is a grade 3 on both sides. Going further, we have here the lumbar spine. Of course, in the X-ray of the lumbar spine, in the anterior-posterior projection, we have the imaging of the sacroiliac joints again, and some institutions prefer to have just this image and do not do a proper pelvic X-ray. But if you are going into the physics of X-ray and into the projection technique, you will come to the conclusion that it's always better to have a full pelvic X-ray compared to the lumbar spine X-ray with the sacroiliac joints image, because you need to remember where is the central beam. The central beam is the place in the X-ray that is centrally located, and that's the one spot where we have a true horizontal X-ray beam with a true anatomic depiction of the bony structures. And the more we go to the outside of the film, we have a distortion and geometric distortions. And if we have here the central beam in the middle of maybe L4, then we have more distortions lower here, and maybe also some unsharpness that can occur. I mean, X-rays are always difficult to interpret, and maybe the difference is not so big, but I would always go for pelvic X-ray. Okay, so looking at this lumbar spine, we see there's no scoliosis. It's very straight, which is very, very good. We see the chronic sacroiliitis. We can look here at the spinous processes. That's very important. There's no bone between them, though there's no ankylosis, which you would expect in long-standing disease. We see here the pedicles, how they connect to the vertebral bodies. We, of course, try to see the facet joints, but this is always difficult. You see here the cleft of the facet joints, the joint spaces. They are not well visible here because they are obliquely tilting downwards. And we would compare this with the lateral view. And I think, again, this lateral view shows us some remarkable findings that we would expect in the radiographic form of axial spondyloarthritis. We have these, this is the L5 vertebral body with normal contours of the bones, nice anterior edge with rounded corners, with the normal height of the intervertebral disc. But here we see this bony outgrowth, which we call the desmophyte. We also see the sclerosis here in the corner of the vertebral body, which we call the shiny corner. And we have similar shiny corners over here, all described many decades ago by Dr. Romanus. And so this is the finding. We have two vertebral bodies affected by at least three syndesmophytes. So that is what we can see on X-rays. Dennis, would you like to go over to MRI and show us what we could find there?
Absolutely. So thank you very much. That was a great explanation of X-ray findings, and in fact, the diagnosis could be made already after the X-ray steps. So X-ray still plays some role in the diagnostic approach. But we of course would like to discuss with you also MRI findings, because sometimes X-ray is not available, is not done, and then you would be seeing the changes on MRI we're presenting right now. So first, we have this oblique coronal stir, or T2, with fat suppression, where we're looking for active inflammatory changes compatible with spondyloarthritis. So subchondral bone marrow edema that should be localized not only in the anterior part of the joint, but rather in the mid part of the joint, cartilaginous portion of the joint, with potential extension to the anterior and posterior parts. So what do we have here? I'm going now from the ventral part to the posterior part, and I see that in the ventral part there is not that much of bone marrow edema, and approaching cartilaginous portion of the joint and going over to the transition area and to the posterior part, I see some bone marrow edema, which is localized subchondraly, which would be already well compatible with axial SPA. So the MRI gives you also a sense whether the disease is burned out in this anatomical region, or whether you have still inflammatory activity, meaning the patient might need anti-inflammatory treatment. So bone marrow edema is present there, and you can suspect already on STIR that there might be some structural changes, but STIR is not good for the depiction of structural changes. We discussed it before that T1 used to be many years a standard for the detection of structural lesions. Now we tend to apply T1 weighted sequence with kind of erosion sensitive sequence that can be again T1 with fat suppression and thin slices, or a specific sequence like WIPE, THRIVE, or LAVA. So in this case, the MRI was done externally, and as you know, not in all radiology clinics in erosion sensitive sequence is a part of routine protocol. We're trying to change this, of course, but in this case we would be it would be sufficient to look just at T1. So what do we have here? What can we recognize? We can appreciate the presence of fatty metaplasia, and this is a young male patient, so we do not expect that much of physiological fat. And this fat, what we see here, we compare it to the mid part of the sacral bone, and we see that this bone marrow is still active in terms of hematopoiesis, and that's why it is dark. And this one, this bright area is quite homogeneous, it's sharply bordered, so it is very likely that this is a post-inflammatory fat metaplasia or fat lesion of the bone. Then sclerosis potentially is also there, but sclerosis is very non-specific finding, so we don't pay too much attention to the sclerosis. What would be much more important is to identify erosions and next step after erosion, so-called backfill, so repair tissue within the erosion cavity. So if you look precisely, you see that there are several lines in the right sacroiliac joint. There is a border of the sacral bone, then you have some white signal, and again another dark signal. So you have an impression that there is some tissue, some fat tissue within the joint space, and this is what we call nowadays backfill. So this black line is a line showing you the previous line of erosions, and now these erosions are in the stage of repair. So this is backfill, repairing erosions, and at the next step giving an origin to bone butt and to ankylosis. On the left side, where we have a similar picture, you see that the bone structure is quite messy, especially at the iliac side, and this is again a sign of previous damage, and now this damage is somehow repaired by new tissue, by granulation tissue that would be ossified at the next step, and again would likely obliterate the joint space. So even in the absence of typical erosion sensitive sequence, we see that there has been erosive damage there, which is now at advanced repair stage. So that would be highly suggestive of spondyloarthritis with symptom duration of about 8 years. And you saw that this case is a rather severe case with already spinal involvement and presence of some syndesmophytes. We have also a couple of other planes, so axial or semi-axial. These are truly axial planes where we can differentiate between anterior and posterior portions. In this case, they do not provide that much additional information. We see the same active inflammatory structural lesions as on oblique coronal slices. So also in this case, we were talking about axial spondyloarthritis, but you see that even nowadays, people are coming to a rheumatologist for the first time with question about axial spondyloarthritis after many years after onset of symptoms. So this is happening. So and that is why it's quite important to keep in mind the whole spectrum of changes. We started with case number 41 today with early changes, with early case of axial spondyloarthritis, and then in case 42 we were looking at more advanced changes representing the whole spectrum of what we can see and what we consider nowadays compatible with axial SPA.
Would you see we saw the whole spectrum? Because is it more advanced or is it fully advanced?
Yeah, you're absolutely right. Yeah, on the X-rays, you suggested that there might be ankylosis. On MRI, we couldn't appreciate clear ankylosis. Probably it's just one step before that. So the next step, the full spectrum, would be to demonstrate also ankylosis. But it might be also a little bit boring, right?
Indeed it is. So we should search for a case with full ankylosis and present that maybe in one of the following sessions, because I think that is also something very interesting to see how ankylosis is seen on CT, on X-ray, and also on MRI, because the joint is very long, still visible, and this is very interesting. So this selection of cases was wonderful, just missing a little bit the MRI of the lumbar spine to compare how the syndesmophytes look like on MRI. Maybe we can also add that during the year with a case of that one.
Yeah, something to discuss for the next time. So thank you very much, Kai, for the discussion of the cases today with me. Thank you very much for listening. Stay tuned. We'll be coming with more cases in the future.
And if you have a case for us to present for interpretation, a differential diagnosis, or some severe case, or some case that maybe has imaging done wrong and we should discuss, we are happy to take your submissions and to screen them if they are suitable for this educational endeavor. See you at the next time.